Welcome to the Healthcare Leadership Experience radio show with your host, Lisa Miller. Lisa is an entrepreneur, inventor, advisor, and founder of Vi Healthcare Consulting, the leading healthcare advisory and analytics firm, helping hospitals accelerate their margin improvement goals. Lisa loves to think differently and collaborates with leaders and their teams to solve challenges and to create new, innovative approaches that impact the clinical and business side of healthcare. Our show will bring you leaders and innovators within healthcare and across multiple industries. Be a part of the discussion that will give you a unique perspective, deep insights, and roadmaps to successfully help you navigate the clinical, financial, and operations of healthcare. Your show starts now.
Welcome to the Healthcare Leadership Experience radio show on Healthcare Now Radio. I'm Lisa Miller, your host, and today we welcome back to the show Jim Cagliostro from Vi Healthcare for part 2 of our discussion on nursing. Jim, I'd like to pick up right where we left off. You'd given us a list of some things that needed to be looked at that could reduce burnout for nurses. Let's dig into that list and start off by talking about support staff.
They all are fantastic, and I want to talk about a few of them in detail, but support staff. So can you just talk about, like, there's support staff aides now. Do you think there's other support staff? Like, you made a comment about, the bells, people ringing, and do you think there's anything else that, and I'm completely putting you on the spot here, but do you think there's any other support staff that doesn't exist or maybe exists a little bit that could exist more? Because I think that's really important, right? We talk about it on the business side is, nurses shouldn't be putting away stock, right? That's not a good use time. And maybe they want to put away stock sometimes to get away and do something else, but maybe there's support staff that helps them even in that direct care. Do you have some thoughts? Exists, doesn't exist, could exist?
Because I've worked in a number of different health systems in a number of different states in my work with Vi, I've seen some places that do it great. And we've seen some places where, hey, there's room for improvement here. And so, I mentioned that patient care assistants, and by that, for anybody that most people know, these are people that are trained in terms of what's the safe way to help a patient who's had a certain procedure to help them to the bathroom, or to sit them up or get them over to the chair and set them up for a meal, for recognizing, okay, there's certain restrictions that this patient has, so I can go get a drink of water for this patient, but that one needs thickener in their liquid. Or when do we need vital signs and daily weights? These are all activities that patient care assistants or nurse assistants, depending on where you're at, they have different names, that they can help with. And then it allows nurses to focus on the things that only the nurses can do. And you touched on it, Lisa, where there's activities that really can stretch someone, but if those activities can be delegated to someone else, I talk to my wife about this a lot. You know my wife, Lisa, and she's very much the person it's just quicker to do it myself. I'm just going to do it and get it done. But really in nursing, we have to learn to delegate some of those tasks that can be done by others. But if the staff isn't there, if there's nobody there to delegate it to, then it ultimately falls back onto the nurse. Other things I'd say, I've worked in places, they have a secretary where it's literally someone that answers the phone. Every call that comes into the unit, it goes to that person, and then they can triage the phone calls basically and say, okay, I can contact the nurse for this, or this is something I can deal with, or I can get the appropriate person. So that really minimizes the need for, a nurse is doing patient care. Well, they have to run over to the phone because somebody's calling. And another thing is volunteers. I've worked at places that have a great system of volunteers, and sometimes patients just need someone to sit with them. I'm telling you, me, Lisa, I love on my 12-hour shift just to sit and chat with someone, and just, they're lonely. They haven't seen a visitor in a week, and they just need someone to talk to. They want to reminisce, or they want to talk about what they're struggling with. Sometimes a volunteer just to come and sit with someone, talk, get them a newspaper, go down to the snack shop and get them a snack, things like that, where again, nurses can focus on the responsibilities that they're able to address, and volunteers can really help lighten that burden and really provide an excellent experience for patients. So those are a few things that come to mind.
Yeah, so I love the volunteers, and I had a personal experience. My daughter was in the hospital, and we were in a children's wing of the hospital. And it's interesting because I think that anything to do with children, people tend to be more innovative, and you really could do the same thing anywhere really in a hospital, but we tend to, for obvious reasons, to be more innovative, and there's not maybe to understand the environment, and they're little. But this young man that came in, and I would say he was about 17 or 18. And he would just come into the room and talk to me, talk to my daughter, and really just chatting with her. He's like, oh, I'll go get coloring books and I'll color with her. And I'm just like, okay, who are you? Like, this is great. I mean, he was great. I mean, I knew he had a badge and I knew he was there, legit. But I'm like, what's your role? You got to tell me your story. What's going on here? And he's like, oh, I'm going to start medical school. And I have a program here at the hospital where I can volunteer. And he wanted to be a pediatric orthopedic surgeon, which is amazing because he was not even in medical school and he knew what he wanted to be. But of course, that may change. I thought it was fantastic. Like, you wonder whether it's, the volunteer from a traditional community or those young people who are going into medical school. What a great way to say, listen, this is a great way for you to kind of learn a little about direct patient care and doing some volunteer work. But he was fantastic. Like, he took his volunteer work very seriously.
And that one person can change the entire experience for your daughter, for the whole family. Yeah. That's wonderful to hear stories like that.
Right. And you just wonder how many more of those that happen throughout the country. And, you just get everybody learning and implementing. It's the other thought that always is in my head is you've got all these great models or systems and experiences or things that nurses are doing. And we just need this big pool of putting those ideas in so people can take them out and bring them to their own hospital, because I think there's so many of those throughout the country.
Oh, yeah.
All right, we're going to dig in a couple of more. Better staffing. So that's something that seemingly could be fixed easily in the sense that sometimes it's poor planning, poor management. Sometimes it's real and just as a series of events and there's staffing shortages. But my guess is some of it's just could be better at staffing, right?
Yeah. 3 things come to mind. One is state laws. So every state should, I don't know if every state does, but states will have a minimum nurse to patient ratio. And so if you have this number of patients, then you need this number of nurses. So that's one thing. But a hospital doesn't necessarily have to meet they have to meet that as a minimum, but they can have better standards in terms of, okay, the state says 5-1 or 4-1 on this step down unit. But we as a hospital are going to say, no, we're going to say 3 patients to 1 nurse because we want to provide better care. And yeah, it's going to cost us more maybe upfront, but in terms of the quality of care, in terms of safety, in terms of preventing falls or infection or things like that, it might end up saving us money in the end if we have a better nurse to patient ratio. So they don't have to meet exactly what the state is saying. They could provide a better nurse to patient ratio. And then the other thing you touched on was staffing and managing the resources, in this case, managing your personnel, the nurses, in a better way. And a lot of hospitals will have a float pool to say, okay, we know of this 500-bed hospital, there's going to be 10 to 15 nurses that call off each night for whatever reason, sickness or whatever happens. So now we have a float pool that is coming in every night. And this float pool, instead of staffing it with 8 nurses per night, we're going to say, let's have 12 to 15 nurses coming in ready to fill those gaps. And again, that comes down to a healthcare system making the decision to say, okay, we might have an extra nurse. Well, we can provide them to a unit that needs the help tonight, whatever they're going through. Or maybe there's a code in one area and they can go and help in that area because a nurse isn't available. Things like that. So it's definitely managing personnel in a way that says, okay, patient care is a priority for us. It's not just saving where we can here and there, but we need to make sure that the hospital is staffed well.
So you just taught me something. It's true, right? You always hear we're meeting our requirements or the flow pools are matching some kind of historical analysis. But to say, you know what, we want to be 25% greater than our needs on a flow pool. We want to be greater with our ratios makes more sense. So everything you named, and happier nurses not leaving the profession or going somewhere else. It just seems like such a solid solution to say we're going to do the opposite. And sometimes when we do the opposite, it ends up being better in a lot of different ways, right? Not following what everyone's doing and saying, listen, we're going to actually overcommit on nursing, overcommit on the flow pools, and they probably would have a tremendous impact. It would probably be way more cost effective.
And that will trickle down. You think of the impact it would have on the staff, where you just see, hey, leadership cares about us, but that's going to impact the care that they provide to patients. And patients are going to recognize that. That type of decision making, that type of prioritization can really have an impact hospital-wide, system-wide, if that's something that people will see a difference. And it might take a while to see it, but people will see that difference.
Yeah, I agree. I think they will. If you're just tuning in, you're listening to the Healthcare Leadership Experience radio show on Healthcare Now Radio. And I'm Lisa Miller, your host. This show is sponsored by Vi Healthcare Consulting, the leading healthcare advisory and analytics firm helping hospitals accelerate their cost savings and margin improvement goals. We've been helping hospitals since 1999, and you can learn more about Vi Healthcare at viehealthcare.com. So the last area as we wrap up is around leadership. So you mentioned two things. You mentioned leadership that listens. I want you to expand on that, and having a seat at the table, because I think those two are really important. So if you can tell me what you mean by leadership that listens and how hospitals can have nurses in leadership that have a seat at the table, like if you can just expand on each of those.
Definitely. When it comes to leadership that listens, I would say, in my mind, probably the key there is leadership that's initiating the conversation. Because a lot of times the busyness of what's going on the floor, and sometimes you don't even know where to start in terms of, well, how do I reach out to usually a manager? Sure, if there's a manager of a unit, you'll see them. But sometimes on night shift, I worked night shift much of my career, you don't necessarily see your manager, except in passing when they're running, to start the day. So I think it's good, whether it's from the unit manager or from the director of your department or from even higher up the C-suite, to see that they're initiating the conversation. And they're maybe even walking onto the floor at change of shift. Maybe that's a busy time to do it, but touching the day shift and the night shift and saying, hey, we're here to listen. What concerns do you have?
Before we go to the next point, I'm sorry to jump in. Have you ever seen a CFO walk the floors in the night shift?
Not a CFO. I know we've seen, I want to say the director of our department, I want to say director of perioperative services. I would cover until like 1 a.m. in one particular hospital that I was working. And you would see them maybe like 8 or 9 o'clock at night. So they're catching the night shift, but not necessarily. You know what? I think on like Thanksgiving or Christmas one time, I remember seeing someone like there just greeting people. And it was somebody in the C-suite that was just there to say, hey, thank you for what you do. So that's great. But it's something that I know didn't happen often, and it depends on the system you're in, to say, hey, it's not just, hey, thank you for what you do, but asking questions, what can we do to make your lives better? What can we do to help you care for your patient?
So I'm going to go off on a little quick tangent here before we talk about, we end with getting nurses at leadership, a seat at the table. I've watched several episodes, but Undercover Boss, right? It just gets me thinking every single time. It would be very difficult for a hospital CEO or someone in the C-suite to kind of do it undercover, but they probably could. And it's always the same story, right? It's someone's owner, leader, and is going undercover in their own organization, completely disguised, and they've got to do jobs that they know nothing about and they have to learn, and they're clumsy through it. Meanwhile, it's their own business or the business that they run, and they meet people and they hear stories on the front lines where they see things that have to be changed. It's like every episode. I've just given everyone the episode. It's just a matter of what do they see differently, what stories do they hear, and how they're touched by it. But it's so fascinating to me that every organization has these stories, has these people, and why aren't we just doing it regularly, just making it part of your routine, your weekly routine? I'm going to go to this floor and have those conversations. So you just got me thinking about Undercover Boss. Binge watching.
Well, on the flip side of that, I'll just share a brief experience. I was caring for a patient, and if you have somebody that's high up in the hospital or health system, but they're a patient, I mean, every patient looks the same. We all look terrible in those patient gowns, right? But you walk in and you don't necessarily know. You see a name and you see them in the gown. But I was caring for someone who ended up being the head of anesthesia in the hospital that I was working, and didn't realize it until maybe going back and one of my coworkers mentioned it. But on that side of it, it's like we need to be treating every patient like they're someone extremely important, because every patient is someone extremely important. But it's our human tendency, oh, this is someone that might be responsible for, or someone that could make me lose my job. I better be on my best behavior. Well, we, from a nursing perspective, need to have that attitude for every patient that comes through our doors.
Yeah, that's
So
a great
that's
point.
got me thinking on the flip side of what you said, but the undercover boss thing is a great perspective.
Yeah, no, and yours is as well. It's great. So as we wrap up, Jim, nurses in leadership that have a seat at the table, what does that mean to you?
There's something, a concept, and there might be different names for it, but one place that we saw had something called shared governance. And so that's something where they bring in nurses from various areas of the hospital to come together. And this one particular hospital, they met monthly. And one thing was the pre-op checklist was something that they were working on. How can we make this better? How can we make it more efficient? How can we really make it so it's the best for the patient and the best for the staff? And they worked on this for months, and it's something that, changing the language, adding things here, taking things away there. And unfortunately, the concept of shared governance was great because it was in place there. And they said, okay, we want the nurses to have a voice. But then the decisions that were made ended up going up the chain of command and back down, and ultimately no change was made.
Yikes.
And so it's a discouraging thing where you spend all these hours and months really cleaning it up and making it right. But then, so at least in concept, there's a seat at the table. But then when you see, hey, nothing was really done out of all these hours that were put into it, and you realize, well, do we really have a seat at the table? Is anybody really listening? So there needs to be something, even the conversation from the higher ups to say, hey, well, this is why we didn't go with those changes. But that can be very frustrating for staff that has poured in their time and their energy in terms of saying, okay, we have a voice, we have this concept of shared governance. Well, is it really making a difference? And I think the responsibility ultimately does fall on leadership to say, okay, we want to listen and we want to make changes based off what the front line is telling us.
Yeah, absolutely. I think that's a great story, and it's a heartbreaking, frustrating story to hear that, because people want to be part of change and innovation and really want to give, their information and their hard work to collaboration, and then not to have any of it taken is not good. But the interesting part about that is that I think that's another avenue for hospitals really to say, listen, how do we engage more? I mean, engagement's not just, it is for the people who are getting this seat, but it's also a benefit to the organization. No one knows best, those in the front lines. I'm a big believer in frontline driven innovation, and I think that needs to be tapped and harnessed a lot more. And
yeah, I was just amazed by this. I forget where I heard it, but they were building a new section of the hospital or redoing it. And they said nurses come in, and they were asking the nurses, what is the best height for the outlets? Like something as simple as that, but you want the nurses are the ones plugging in and pulling out. So I love to hear examples like that where they're really listening.
Yeah. So interesting. I had the reverse happen. Again, my daughter was in the hospital and I had to take her into the bathroom. Now this is a new wing. So I had to have her IV pole in. I couldn't get her IV pole in. Nurse said, they didn't ask us any of this. They didn't come through here. There was something particular about her, the IV pole, and we just couldn't get it in. And I'm like, wow, this is brand new. And they were like, yeah, the door closed the other way. And it was just awkward. And oh, they didn't ask the nurses anything about the rooms. And I'm like, wow, it's so fascinating. If architects and engineers, really smart people, yet you don't go to those who are working to say, how does this flow?
Impacted by it. Yeah.
Yeah. And I always remember that because every time I brought my daughter in the bathroom, couldn't get the IV pole in. It was getting her in the bathroom and we're kind of in between stretching the pole. And the nurse is like, yep, they didn't ask us. But, there's so many lessons here in this discussion, and you just wonder why it takes burnout, COVID, frustration for us to kind of be at this place. And it's unfortunate because so many of these fixes, I think, could be really easy. And I don't mean flip the switch on easy, but they're solvable, right? These are not unsolvable challenges. So Jim, thank you for your time today. This was fantastic. I wish we could continue the conversation, but we've run out of time. However, we are having a conversation next week on the OR, and that's going to be a great conversation. So thank you for being here.
Definitely. Thank you for having me. I'm looking forward to our next conversation.
Great. So you've listened to the Healthcare Leadership Experience. I'm your host, Lisa Miller, here on Healthcare Now Radio. Join us every week, and we thank you for listening.
Thank you for joining Lisa Miller for this episode of the Healthcare Leadership Experience radio show, sponsored by Vi Healthcare Consulting. If you enjoyed the show, Subscribe so you can automatically get notified when new shows premiere weekly. Don't forget to leave us a review so more healthcare leaders like you can discover us. This show is on Healthcare Now Radio, Apple Podcast, Stitcher, Spotify, Pandora, and other major podcast platforms. To reach out to Lisa personally, you can join the conversation on LinkedIn, where Lisa continues to have discussions on the business of healthcare. You can find links to Lisa's other social platforms in the show notes or at vihealthcare.com. The Healthcare Leadership Experience radio show is the Think Differently communication for healthcare leaders, and we are honored to have you tune in. Join us next week for another episode of the Healthcare Leadership Experience radio show.